Dr. Woos, please. Before we start, there was a question. Who asked me the question about the blue color? I think it was you. So we had a question that in the video of Dr. Woos, there was a blue color with the fragment that was going. So the question was, Dr. Woos, is it from the light? Is it the reflection? Or what is this blue color?
It's indigo carbon. I said I do discography in every case. And I use half 3 millimeters of indigo carbon and 3 millimeters of radiopac and make it 10 millimeters of solution with saline. So indigo carbon stains the pathological nucleus and guides you through the operation. That's why they are blue, not because of reflection.
Methylene blue, you can use methylene blue.
Huh?
You can use methylene blue also.
I know methylene blue is not that much specific to discs. Indigo carbon is it likes plastic medium, so just go to methylene blue, you see everything blue. But indigo carbon goes to pathological. Look at some questions. I want to, Mata,
yeah.
I now explained the technique or in Cadaver, whatever you want.
I think it's better now to do it theoretically because the cadaver might be a challenge. We're going to try, but it might be a challenge. But I think
the trajectory, of course, as Mother said, there's different schools. Dr. Gori and this Lubers who trained me and Dr. Rutan, they all love extreme lateral. The philosophy, I'm going to tell about the philosophy between this. As you, Dr. Fazal, you see here now? No. With the posterolateral technique, so I can say anything, yeah? It's not okay. This is, the epidural space. This is the PLL. And this is the cyst, right? If you are in a posterolateral trajectory, you come like this. Yes?
yes.
I'm not to come like this. So in the video, we saw the same, the PLL, the epidural space, and the disc space. Yes, that's true. But you can have this vision only when you enter. You understand me? Just enter. Just if you are here, the beginnings of PLL. So if you go, if the fragment is here, if you go, you are always going away from the fragment. So you cannot take this fragment. You just look. You see. Maybe you can use the 90 angle 2, but you can never do it. It's not easy to manipulate. It's not possible.
Even if you complete the movement is very good.
Yes.
Even if you take
you can take this PLL, yes. Better vision. But when you enter, if this has fragments in the midline, you never take it. It's impossible. So the main difference in the technique I am using, I go like this. I can draw it here. With this. You understand? And I said, in the vision, this PLL should be in the lower part of the vision. So if you take it, come, it doesn't matter. You are always epidural. This is the philosophy under epidural technique. In this technique, if the disc is here or here, contain discs, maybe you can take it. But for extruded disc, the castrated disc, you can never reach this place. It's impossible. So sometimes some guys use PLF, posterolateral technique, and also adds foraminoplasty. This is the result. If you do foraminoplasty, you can do it here like this and see the accuracy.
So how do you come? How do you come that? You see, we saw the marking.
Huh? I don't know. He is really asking. Always asking, but no. The entrance point is really important. On the AP, as I said, the drawing may not be good, but this is this space, yes. And if there's an ER bone, I have to come like this, yes. So I make a mark on the patient to my trajectory on the AP, yes. And I turn the scope lateral, and on the lateral, these are the facets. Yes, I put my right here and make another drawing line, and this line where they intersect. You understand? It's my entrance point, and the inclination is almost 5 to 10 degrees. Yeah, because I want to be at 0. Yeah, in PLM, posterolateral technique, you have seen that the inclination is like this. In my technique, the inclination is like this. So entrance point is here. Then you decide the inclination, see AP, and when you touch the facet, see lateral, and go in the facet and go in the disc. And you have asked, normally, the puncture point should be medial pedicular line and posterior vertebral line, yes? And he said, your always pin is like here. This is why I saw that picture. Yes, I puncture here, but even I go, it is still here. You understand? Otherwise, I should see like this. When past the midline, the pin should be here. In the posterolateral technique, you will see here. But you have to see here, even you advance your working condition.
So are you sub-annular or you are supra-annular? You are supra-annular.
Most of the time, supra-annular or just annular. I see in the below the half of the screen. So I cut some and stay almost supra-annular. And before finishing, I go increase my inclination, go in the nucleus, take 3 fragments.
Anybody has question? Please ask any question. I wanted to ask about you go posterolateral sometimes.
Yes, for extraforaminal.
Extra
only.
So you go directly on the fragment, posterolateral.
No, I use the Lumbar stick. So I go just in the nucleus and come back and turn to foramen. It's safer.
So it's a combination of inside out, outside in. It's a combination of
actually, there's 2 main techniques. You can put your working cannula and endoscope to pedicule, okay, inferior pedicule, and find the disc space and go to find the exiting nerve root. This is the technique. You use oblique one. This is the Rutan's technique. Lumbar's technique. You go in the disc, go out, and turn to foramen. And it's safer there. And then look for the fragment.
Excuse me, when you're doing the turns, you're doing them on the porosity.
Excuse me?
When you're doing the turns, you're doing them on the porosity.
Time for fluorescence.
So when you're turning, you're doing the turns.
I still don't understand.
Saying, are you using direct vision or are you using telescope to guide you?
For endoscopy, no. Just check it after I'm in foramen, checking with endoscopy. But normally, with endoscope, endoscope and the working canal in, I go outside and I see annulus. When I see annulus, I barrel like this and go to foramen. And after that, one shot, if I'm in the foramen or not. Just one shot. So,
It's ready.
in some cases, I have to use interlaminar, especially really sequestrated, up-migrated, and L5S1 cases. Sometimes my friends tell, why are you forcing transforaminal? Because sequestrated and down-migrated or up-migrated discs are really hard to do with transforaminal. And my answer is, they are hard to do also with microdiscectomy, with interlaminar technique. These discs are hard. It is not because of transforaminal is not effective. These discs are always hard to solve, even with microdiscectomy. You have to take a lot of bone. And sometimes you finish operation, you say, okay, I am satisfied. And the fragment is there, missed fragment. For L5 anatomy, L5S1 anatomy, for L45, it's not a problem. But the iliac bone is a real issue for L5S1, especially in some cases in male patients, as my colleague told, it's a problem. And as he also told, sometimes you can enter from the same entrance and do L5S1 and L5. Okay? But one thing he said, I'm really not happy here, but he said, if you cannot enter L5S1 from your trajectory, just try to do, no, you are going to do L45. They are the same place, he said. You remember?
Yes.
I don't accept it, actually, because if you cannot enter from here, it doesn't mean that if you enter from as if you are doing L45, then you can find your way. Never do then transforaminal. Go interlaminar, microdiscectomy. Because entering to this doesn't mean that you are going to take the fragment out. You have to place your working canal to the exact place. It's, I think, very important. Transforaminal, as I said before, is sometimes hard for L5S1 because, the iliac bone, big facet, and everything. But interlaminar is a good technique for L5S1, as most of the time, the interlaminar window is very big. So you don't have to take bone out. Yeah, you don't have to cut bone. So in case transforaminal is hard, I think this technique should be chosen. And as an endoscopic disc surgeon, in the very beginning, I was against interlaminar. And actually, most of the endoscopic surgeons, when you ask, they say, I'm transforaminal guy. The others say, I'm interlaminar guy. And they do one technique, apart from Dr. Rutan. For an endoscopic surgeon to be successful, has to do both techniques. It is a must, because if this is impossible, then you're going to do open surgery. No, you can use interlaminar technique. I told about the anatomy. Actually, I didn't know that I'm going to, pardon, I'm going to make a lecture about interlaminar. So I gathered all my, data together. For posterolateral transforaminal technique, it can be foraminoplasty transiliac. Interlaminar technique can be used as a shoulder or axilla. The techniques differentiation is this. Ligamentum flavum is protected, is resected. Annulus repair not possible. They say possible, but according to me, annulus repair is not possible also with interlaminar. Just annular sealing is possible. I'm going to tell about it. And indications are limited. Indications are wide, because you can do any operation, especially now. I am sure you have heard unilateral biportal endoscopic discectomy. They do any case, even degenerative spine, central canal stenosis with this technique. And fibrosis, as I said before, minimal, not reported. With interlaminar technique, it's possible. Anesthesia can be local, epidural, or general. With local, it's not comfortable. Motor block with local is, a bigger problem when you compare to general without muscle relaxants. Root irritation is possible with local, with general, no. Wake up is possible with local, and with general, not used. The position is a little bit different for interlaminar. The patient is hip flexed, lumbar flexed, and you should put your hand to the back and feel the straight or the rigidity of the soft tissue, which means that you open the interlaminar area and the ligamentum flavum is tight. If it is not tight, it's impossible to, not impossible, but very hard to cut ligamentum flavum with endoscope. So you put your hand here and tell the assistant, bend, bend, bend. When you're satisfied, you can begin the operation. And also what Dr. Rutan told me, never think that, okay, it's not rigid anymore, but I will do it. It doesn't occur. He say, position again the patient, and then begin. Position is really important.
When is your starting point? It's soft?
It will be tight. Tight, very tight.
That's your starting.
Yeah, because that means interlaminar window is widened, and the ligamentum flavum is tight. So when you cut, it's easier. But when it's soft, it's really a big problem.
It means that to have it tight, it means as if I'm standing like this.
Yeah.
Yeah.
Flexion, flexion, flexion.
That's why the window is open in that case.
Yeah.
The vertebra is
Yeah.
Okay. Makes sense.
The incision is just lateral, very close to Spiders process, and your target is here. This is really important, my friend. You have to enter ligamentum flavum very near to fascia. Otherwise, you will end up with neurological problems. 100%. So your target point is here, So you are going to make the ligamentum flavum incision here. Distal oblique is really good actually, because when you push the ligamentum flavum, make it tighter and you can cut it easier. And also you give less muscle injury. You can see the axilla with straight one, it's very hard. And you can ecartate the dural sac with this, working canoe, but it needs little expertise. There are different techniques. Resection, which I also use, it's easy and classical. Choi, indirect blunt puncture. I tell you a lot, it's very important to be lateral. Just go in with a needle. Really, I have seen it. Just go in with a needle. Blunt entrance. But he go very lateral and he says, there's no neural structure there. But I never tried and I will not try. Direct puncture, in this technique, they go to the ligamentum flavum and put the endoscope, and with sometimes RF, they make a hole, and the water pressure takes the neural structures out and then cut. This is logic. Learning curve is for shoulder, it is short. For axilla, it is flat. Inferior migration is difficult in shoulder, but easier in axilla. You can imagine. You can see the fragment if it is down migrated. Superior migration is easy in shoulder. I have never seen superior migration in axilla, but it's difficult. Root retraction is strong. There is no root retraction in axilla. Just you can take the sequestrated fragment. Annular sealing, which you open the annulus. So with RF, you want to shrink the defect. This is called annular sealing. It's easy in shoulder, weak in axilla. This is axillary approach. This is shoulder approach. Most of the time in L5S1, this is shoulder disc herniation. This is what you see. You take the neural structures and the fragment is here. This is the axillary view. You see the disc fragment here. Just take some epidural fat here and you see the disc fragment here. This is a patient. Today, maybe I would do it transforaminal, but it was a big one, so can you see? Yes. I will show the video. For L3-4, the interlaminar window is not big. First, you take the ligamentum flavum superficial, and you have to cut some bone, the shoulder of the lamina, just to widen your window. You see, some guys take the flavum before this procedure, but I believe it is more safer to keep this deep ligamentum flavum and then do the bone resection, because protects the neural structure, and then cut ligamentum flavum.
Okay. So how do you stabilize your sheet here?
You hold it.
Oh, okay.
With one hand, yeah. And after taking some, this is the ligamentum flavum. Now we are going to enter. You see, when water comes in, all the neural structures goes down, and you have some working place, safe place. And then use the knife. You can see the neural structures. Sometimes there is epidural fat, but you can take with punch and you can see this. And as I said before, the important thing is go as far lateral as possible. Yeah, this is very important. Use carousels, and you have to go lateral to this root. Otherwise, you cannot ecartate anything here.
But your incision is close to the spinous process, 1 centimeter.
Yes, but you go laterally this way, yeah, and use electrocautery just to, and this root is always displaced, not in normal place, because of you have experience with microscopic surgery, so this is here. I can't see it, but I have to ecartate the root. I will do it with the working canoe, but I need little place more just to put the oblique working canoe. Yes. I have to prepare here and put the beak there, so turn it and the neural structures go midline. Yes. You see? Now I'm going to put the canoe, working canoe. I saw because I can, ecartate. Yes, I'm putting it. Oblique side looking to spinous process. I was not successful, so we'll try again. No, I was successful, and the disc came here, yeah? Yeah? There's the nerve structure. It's you must control it just by turning it. As you use it as a joystick. And now I took the disc inside. Nerves are all midline, so I can really work safe. And you always relax the nerve roots in every 3 or 5 minutes.
So you're using the straight canal?
No, oblique. Always oblique.
Interlaminar, always oblique.
Yes.
Transforaminal, oblique.
Oblique. Posterolateral, straight, yeah. Now you will see the remnants of the disc. Take them all out. These are not modifications. These are 2 different operations.
How much of the disc do you take?
Huh? Just take the fragment, and then enter the. Sometimes you cut some annulus. Sometimes the ruptured area is enough. So enter in the disc and take loose fragments. That's all. You see? Now it's more easy to ecartate. There's a fragment also. So take it out. And under, you see? Under the annulus. You have to look there. And after that, I will do some annular sealing. I mean, with RF, I will try to decrease the ruptured area. Turn the working canoe, and yes, this is annular sealing. And also this is very important for post-operative MRI. If you leave that, they sometimes think this is, you know, missed fragments. Now I'm going to show another interesting case, L5S1. Can you see the window?
Yeah.
Yeah. And the iliac bone here. And it cries. He's interlaminar. Transforaminal is not good for this case here. Very big interlaminar area. The placement of the things. And you know, maybe you think this is not a big one. But can you see the root here? Just pressing the root. I'm going to show in the video. You cannot believe. Just root is like this, and this is like this. Yeah. So the patient was really painful. Look. Take some superficial ligamentum flavum, enter in, again go lateral, just this place you have to dissect. It's very important. You see the root is high end, and now please look, this is just under the root, really pressing one, and eccartated, but comes again. You see the fragment, small but really displaced.
Oh.
Yeah. And the operation the classical way. Conclusion, especially for L5S1 cases with high iliac crest, high cranial migration, this is the main problem because we do it minimally invasive but cut the ligamentum flavum. It's very similar technique and anatomy with microdiscectomy and shorter learning curve. Thanks for your attention.